Hello, everybody. This is Sarah Edwards for Block 3 Immunology. Welcome back. I'm holding the microphone to my face now, so hopefully the sound's going to be better. But yeah, so it's going to be the same format as the last block LGT. So I'm going to have all these presentation materials. We're going to have all the practice problems at the very end. So if you want to skip to that now, feel free to do so. Yeah, and so I just want to remind everybody that the PowerPoint should still be uploaded to the Canvas page. So if I accidentally block something or if it's not very clear, you should still be able to follow along on either the PDF or the PowerPoint that I have Miss Peggy Till upload. So without further ado, let me make sure that this is actually going to shift around and change. Okay, awesome. Here's our disclaimer, and let's start with immediate allergic reactions. So these are your type 1 hypersensitivities, and I have here just a summary, wonderful little mechanism of an IgE antibody and a mast cell producing allergic reactions that can be pretty much instantaneous. So let's go through it. So type 1 hypersensitivities, these occur within minutes to hours. So these are an immediate response that your body makes whenever it feels an allergen and it doesn't like it. There is a disease, or a condition rather, called atopy, which is basically where you have dermatitis to a whole bunch of things. So your skin just gets touched by, maybe it's a detergent, maybe it's pollen, bee stings, for instance, you can just have an immediate response. So atopy is, in general, an overproduction of interleukin number 4. This is produced by Th2 cells. And because of this IL-4, B cells will differentiate and secrete IgE antibodies, which, as we will see in a little bit, will bind to mast cells and cause allergic responses. So you have histamine release, later on you have leukotriene release, and you just basically get inflammation, vascular permeability, all the things you imagine an allergic reaction would have. So just to refresh you, allergens are antigens that cause type 1 hypersensitivity. So not all antigens are allergens, but allergens are a form of antigen. I would like you to remember that. And then here's another diagram to kind of show the process of, we've got a Th2 cell, has the IL-4 that's stimulating the B cell to differentiate, release IgE from the plasma cell, and then it binds to mast cells and causes all sorts of recruitment of inflammatory mediators, etc. All right, so specifically with IgE and mast cells, so we already talked about secreting too much IL-4. That's very important to know. So these will cause mast cells to degranulate, and they're going to produce mediators. So these mediators are either acute or early phase or late phase. So in general, they're found in the mucosa epithelial lining. And they're generally going to recruit other inflammatory cells like eosinophils and basophils to fight off whatever allergic response or whatever the allergen is. So the acute phase is usually going to include things like histamine and heparin. These are released almost immediately from the mast cell during degranulation. Later on, however, mast cells can secrete or produce and secrete prostaglandins, leukotrienes, platelet activating factors. So the late phase is responsible for that prolonged effect. So even though you had an allergic reaction, maybe later on you still have a rash, or maybe it's swelled and expanded, and that's that late phase happening. Just to refresh you on other allergic conditions, we can have allergic rhinitis and then allergic asthma. You can think of the, the hypersensitivity triad or the atopic triad, where you have allergic rhinitis, asthma, and atopy. So they all kind of have similar things going on. In allergic rhinitis, you have mast cells that activate in the nose area specifically. So that's where you get a red nose. It gets kind of puffy. You start dribbling snot. It's not very fun. And here are some different treatments you can use to take care of them. So if a mast cell is releasing histamine, you might want to use an antihistamine to take care of it. Decongestants for if you get stuffy, leukotriene antagonists might help for more long-term help if you have a really bad problem with allergic rhinitis. But you typically want to start with the top here and go down. And then if it's chronic, then you can use fluticasone, for instance, long-term. As you learned in, I want to say it was Principles of Pharmacology, was it called? You kind of learned that steroids or fluticasone takes a long time to work, or maybe it was self-care. Either way, you might be familiar with this. Allergic asthma, kind of similar situation. We have Th2 cells that are causing a increase in bronchial smooth contraction, so you get kind of an asthmatic response as if you had asthma. And you can actually treat this similar to how you would treat regular asthma. So you can have albuterol, you can have corticosteroids. You can use mast cell stabilizers long term. These ones take like a while to work, so it might not be good for an acute case, but for a chronic case, that would be great. And then just to point out omalizumab, the mAb means it's a monoclonal antibody. So this one's specific to IgE, and it'll help like stop an allergic reaction from happening. So if this is for like, I want to say it's like last line whenever none of the other therapies are working, or maybe they have some sort of genetic predisposition that this would be more appropriate for. In terms of skin allergies, it's really important to know the difference between like an immediate, like a generalized reaction versus long term. So in the beginning, whenever you have an allergic reaction and it affects your skin, you're going to have fluid leakage, vascular permeability, so your blood vessels are going to dilate. You've got histamine, heparin, all going around, and you'll get something like a wheel and flare reaction where your skin will turn like red and it'll like get inflamed and raise up. Eczema is pretty much the same, it's just long term, so you're going to have it for a long amount of time. It's not like psoriasis where it's like a plaque, but it's just like chronically red, irritated skin. And this one you're going to treat with topical steroids and sometimes calcineurin inhibitors if it's too much for corticosteroids don't work good enough. It's also important to know the difference between local and systemic. And so this one's really intuitive because local is kind of just like around the tissue itself. You've got a rash, vesicles. If it's like allergic asthma, it's going to be localized in like that throat area. And whereas systemic is going to be all around. So you're going to have like your blood pressure drops, or like you are going to have difficulty breathing, diarrhea. So you're going to have like a myriad of symptoms, and it can be life-threatening. So knowing the difference between systemic and local is helpful in determining treatment. Like, are we going to just use like a topical ointment, or do we need to use like epinephrine, for instance? Urticaria, so this is still a type 1 hypersensitivity. So this is the same thing as like hives. The thing that differentiates it from like, I'm going to say contact dermatitis is that it is immediate, whereas contact dermatitis kind of takes like a little bit to develop. It doesn't happen right away. And also urticaria is more associated with like ingested particles. I think it still can be some topical, but we think of like for instance, food or drugs, they cause this hypersensitivity, and now all of a sudden you have vesicles and like rashes all over your body. So like I said, usually the allergens are ingested. You still have, like, since it's type 1, it's going to be IgE, like coating mast cells, degranulating, causing like histamine to be released, and you get hives under the skin. And so you're going to kind of treat this the same way as you would with the other therapies or other diseases. So you're going to use steroids or antihistamines. And last but not least, I believe before the next slides or the next session is anaphylactic shock. So this is Bear Grylls having an allergic reaction to a bee sting. So this is like systemic, in which now like a bunch of systems are being activated at once. You get like the epiglottal swelling, blood pressure is changing, your airways are constricted. It's really not a good time. And this is where you would use like an EpiPen, for instance, for somebody who has like a peanut allergy, to quickly like reverse the response. So you want to get like vasoconstriction, get that blood pressure back up. And so I just want you to recall that it's still considered a type 1 hypersensitivity reaction, same as urticaria is type 1, same as like allergic reactions are type 1. And then we have pseudo-allergic reactions, which aren't actually IgE mediated, but they seem similar. And so you need to understand the difference between like actual anaphylactic versus anaphylactoid reactions. So at the very bottom here, we have anaphylactoid. So these are like, the best example of this would be vancomycin, because you might be familiar in your infectious disease course where it can cause like a histamine red man syndrome. It's not a true allergy. You can like, the patient's not going to be dying. They just are going to be very red, and they're going to have like a local reaction that's kind of seems systemic, but all you have to do is either like increase the duration, or, you know, like taper it out, or you can give fluids, or you can just like reduce the dose, and give like Benadryl for this as well. There's also complement activation that's not considered IgE mediated, so it's not a true allergic reaction. And then it would be good to know that like there are certain foods and veggies that can cause histamine release. These aren't a true allergic reaction. This is just, you know, like a histamine release mechanism. Other than that, the other ones are kind of intuitive, so exercise induced. So you exercise and all of a sudden it's like hard to breathe. It's not like a true allergy. You're just your body's just maybe not used to exercising for a while. I know I get that. And yeah, so those are the points I wanted to make. So here are the other allergens. You're going to have at least one question on the exam about like matching up the allergen and the protein that's associated with it. So these ones you don't have to remember the numbers, just remember like latex is associated with hevine. And then I put Durex down here because you might know that latex has a cross-reactivity with tropical skin fruits, or like skins of tropical fruits. So if you have like a latex allergy, you definitely don't want to be using this because like then you might have like an additional allergic reaction to it. Dust mites, I just think of like derp, like dust mites. Cockroach, blah, don't want those. And then penicillin can cause like a drug allergy and cause like a morbilliform rash. All right, so on to delayed type hypersensitivity. I found this wonderful chart that basically summarizes like everything, or like the main points you need to know about each type. But just to quickly walk through them, type 1 we just went through, which was immediate. You have the IgE and mast cells. Type 2 and 3, they both deal with like some antibodies like IgG and IgM. However, type 2 is more cytotoxic, where you have an antibody that is attacking a cell surface, whereas type 3 is more like you are taking that antibody and creating like an immune complex, like up here. And then type 4 is delayed, where it's mostly going to be T cells, so it's not necessarily just antibodies, but you actually have like direct cell-mediated reactions going on. So in order of like type 1 to type 4, the onset of like the activity is going to increase, as you can see here. So type 4 is going to take longer, whereas type 1 is going to be more immediate. And then I think 2 and 3 can sometimes be interchangeable, but in general, it's more important between 2 and 3 to know the different types or examples of the hypersensitivities, and we'll get through that in a little bit. All right, so the fast ones are going to be type 1s, 2, and 3, whereas type 4 is that more delayed. It takes maybe, like if you have a tuberculin skin test, it might be 48 to 72 hours later. In this case, it's like it could be a day later. It's T-cell mediated, whereas types 1 through 3, I just want to clarify that like all of these reactions, hypersensitivities, they require a pre-sensitization phase, meaning that you have to be exposed to the allergen at least once. And then the second time you're exposed to it, then you'll have a reaction. Because that first time you're exposed to it, your body might not be ready for it, so it won't be able to recruit cells in time to respond. But that second time, you're for sure going to get like an immediate response, or you're going to get like immune complexes or like hemolytic anemia. It's just that, what am I trying to say here? All of them require pre-sensitization. It's just that types 1 through 3, the next time you get it's going to be a little more immediate. Type 4, you're still going to have something of a delayed response before you respond to that second stimulus. So here are the different syndromes you can get in type 4. So just we can divide them up by like tuberculin and like insect venom. So this would be like a bee sting, for instance. You have contact hypersensitivity. So I know for myself, I'm actually kind of like allergic to, I want to say it's like silver earrings. Like if I keep them in my ear, about a day or two later, they're going to turn red and get like irritated, but it's not immediate. So that's why it's a type 4 delayed response. And then celiac disease is actually gluten sensitivity. So you have gliadin that's found in bread that can cause you to have like, you know, an upset stomach, and it's not very good. But, you know, you hear about celiac and the patients don't necessarily like have an anaphylactic shock. They just get like a really upset stomach, and it's very intolerable after a while. And then the only other thing I wanted to point out here is that with contact hypersensitivity, the antigen can come through the skin, whereas like I want to say gluten sensitivity is more of that ingested reaction. So yeah, I just bolded and like put in red some things that are important to associate, like IFN gamma and TH1 are like more important in contact sensitivity. All right, so for treating type 4 hypersensitivity, the best example would be with like poison ivy, where this is like an inflammatory response. And so I know when I was growing up, my mom's treatment for poison ivy was just to not itch it, just don't do anything. But traditionally, if you do want to treat it and it's too intolerable, you can use antihistamines. So I've got diphenhydramine here, hydroxyzine, and cimetidine actually is an H2RA, and it's going to stop histamine release inside your body. So the highlighted ones are good to know how to treat poison ivy, whereas contact dermatitis is more like you can use prednisone as well for poison ivy and contact dermatitis, but you're going to have some of these more nuanced drugs here like picromulus, tacrolimus, the like immune modulators. But this is like whenever it gets really severe. Like I don't see, besides like maybe triamcinolone and prednisone, like I don't see these two being used so much in contact dermatitis. You usually want to reserve them for transplants instead. But yeah, definitely kind of like know how to treat poison ivy for the exam. All right, transplant immunology. So this is really an interesting concept because in order to do transplants properly, you want to match up HLAs pretty like closely. Like you don't want to have too many differences, otherwise your body might reject it. The thing about blood group matching is that you don't need a pre-sensitization phase for this because your body's already kind of been exposed to a similar substance. What I mean by that is in your body, like in your gut or like you can find it anywhere, you've got bacteria. And bacteria, some of them have like polysaccharide capsules. And these capsules kind of have similar sugar structures to that of like type A and type B, the antigens on top of the blood cells. So that's why we don't need a pre-sensitization phase because your body's already done it for you. So you can actually have a response after your first blood transfusion is what that means. Yeah, you're probably going to have like one question on the exam just matching up like if you have type A, what kind of antibodies are you going to have, and then what's compatible with it. Who's the universal donor, who's the universal recipient. So we've seen that a couple times, so I'll just let you kind of go over the slide. In terms of histocompatibility with HLA, you get one copy from your mom and one copy from your dad, so you can have like a variety of different molecules in your body. And then this is just a refresher about how HLA, A, B, and C, they're all from nucleated cells, whereas HLA-D is actually from more of like those, it's more specific to immune cells. A unique thing about the body is that we have some sanctuary sites that don't actually have like immune cells there. It's basically supposed to be a very sterile environment where nothing comes in. So this will be like your blood-brain barrier, your eyes, and so sometimes you don't need to do HLA matching, at least for like the eyes, because you don't have any immune response against them. So for cross-matching antibodies, so if you want to give a transplant to somebody, you have to make sure that your lymphocytes aren't going to be recognized as foreign by the recipient and destroyed, because that would be very detrimental. All of a sudden, like a kidney is lost or like a skin graft gets rejected, and we don't want that. So we have tests in advance to figure out if there's going to be a rejection or if we need to find a different donor. And the biggest takeaway from that is it's going to be a lymphocytotoxic assay. So this is where you're going to take lymphocytes from the donor, you're going to put them in the recipient's serum. You might add some like complement, some like other material to help like simulate a proper environment for like an immune reaction. And if the recipient's serum attacks the donor lymphocytes, then it's not a good match. So the transplant's going to be rejected. And so this is a great way to figure out in advance if you're going to be compatible or not. And so this is just like an extended diagram of what Dr. Semeka had, but I think just looking at this first column here would be the best in terms of what he would test over. All right, so graft classification, this is like an easy, match the graft to what the, what the donor and the recipient are. So going from top to bottom is going to be the, closest to yourself to the farthest from yourself. In other words, least likely to reject to most likely to reject if you decide to do a transplant. Autograft is yourself, auto. Syngeneic is going to be like if you have a genetically identical twin and you get a graft from them. Allograft is you get from like another human being, so it could be a stranger, it could be your family. And then xenograft is going to be from an animal. I can think of like heart valves from pigs is like the example that's used. There could be maybe like pancreatic cells, different things like that. But yeah, so least likely to cause immunogenicity, most likely to cause immunogenicity. And then there's also a classification of like how quickly a rejection will occur. So if it's like immediate within hours or minutes, even seconds, it's going to be hyperacute. Like you have antibodies already in your system that are ready to reject the transplant, and then it gets destroyed. And then as we go along, we have accelerated, so it's kind of similar to hyperacute, but takes longer to happen. Maybe it's like several days afterwards. We have acute, which is days to months, and then chronic would be a year or more later. So this one's going to be more like the example that's in your textbook / in lecture is your heart vessels are going to like start to thicken, and so you might actually get like a heart attack because now you don't have enough like oxygen going through those like blood vessels, and you could, basically not have enough nutrients to your body. So here again is just kind of talking a little bit about the specifics of each rejection. It would be good to know examples. So for hyperacute, blood transfusions would be one of those because, like we said, you don't need a pre-sensitization phase. You already have like antibodies in there to attack antigens, whether it's A or B. If you had a previous transplant, that's that pre-sensitization phase. So you had it once, you do it a second time, all of a sudden you've got rejection. And then pregnancy. So recall if a pregnant woman is Rh negative, but her first baby's Rh positive, there's not going to be a reaction. But if she decides to have another baby and that second baby is Rh positive, the mother's immune cells will try to attack the fetus. So that's where we use like immunoglobulins to try to stop the mother's body from destroying the baby. For acute rejection, this one, basically just know that you can manage it with immunosuppressive. So we have some time to stop the rejection from happening. So you use like agents that'll stop your T and B cells from trying to attack that transplant. And then chronic is months to years later. So this, like, the damage has already been done. So this is mostly like cell mediated. So it's almost like HLA type 4 where you just already have things going on here. The example was thickened vessel walls. All right, so this one is kind of a not confusing concept per se, but you have to organize everything whenever you're trying to figure out if a transplant is going to be rejected or not. There are two ways that a rejection can happen. You can either have a transplant rejection where the body just decides that that organ or that graft is not part of itself, so it's going to destroy it. Or you can have a worse situation where the transplant has lymphocytes that decide that the body is foreign, and so the transplant is going to attack the body instead of the recipient, and that's going to be graft versus host disease. So for the purposes of the test, you'll just need to recall that tissue grafts are transplant rejections, whereas bone marrow transplants are going to be graft versus host disease situations where you've got like lymphocytes from the bone marrow that are going to try to attack the body. So I have graphs here to kind of organize how to tell if you're going to reject or accept a transplant based off of HLA matching. So if you're talking about graft versus host disease, you care about what the donor is, and the donor is going to decide if the recipient's acceptable, if that makes sense. So for instance, if we have HLA type like 1 and 2 here, it's going to accept either 1 or 2. So like even if this was like A2, it would still be accepted because this guy right here covers both types. So there's going to be no attack. Whereas like if we have like a pure like A1 over here with the donor, and it sees like an A2 here that it doesn't have, it's going to see that as foreign and it's going to attack it. With transplant rejection, we don't care about what the donor has. We don't care about the donor's HLA type necessarily. We care about the recipient type and if it's going to accept the donor. So here we have A1. A2 here is going to be recognized as foreign because it's not part of this A1 here, so we're going to reject it. Versus if we have like a heterogeneous mixture here, it's going to see A1 as like normal or self. And then, like I said earlier, if you do A2, it's still going to see it as okay because we have an A2 here to cover it. So it's not going to reject it. So yeah, the best way I remember it is to remember, okay, is it a bone marrow transplant or is it a tissue graft? If it's bone marrow, I care about it matching the donor. If it's a tissue graft, I care about it matching the recipient. And then here's just a list of the immunosuppressive agents. Corticosteroids are just in general anti-inflammatory, so you can sometimes use those either like orally or, remember for type 1 hypersensitivity would be topically. Antimetabolites, so these will stop like lymphocytes from multiplying because now they're messing with like the DNA synthesis. of certain lymphocytes. You've got calcineurin inhibitors, monoclonal antibodies, which are like they bind to surfaces, whether it's a receptor or a cell or like some sort of like particle, and they'll stop particular actions. And then polyclonal antibodies, they deplete thymocytes or lymphocytes. So I want to say polyclonal antibodies are not preferred. You want to get more specific with a monoclonal. All right, so on to autoimmunity. I'm sorry, I can't speak today. So basically this is where your body is attacking itself, whether it's because it sees something as foreign, or maybe you had like some sort of infection and now your body's out of whack. All of a sudden you've lost self-tolerance. So self-tolerance is where you produce lymphocytes that if they for some reason start like being very broad and attacking anything and not being very specific, your body will try to deplete them and not let them multiply. But if you lose that self-tolerance, now you can have like super active B cells and T cells that attack whatever they want, and that is what causes autoimmunity. The biggest takeaway from that is that if it's central, that's just talking about the thymus or the bone marrow. So that's where T cells and B cells are produced. Peripheral is where it gets out to the lymph nodes and spleen, and so that's like the secondary defense, where like, okay, if central allowed the reactive T and B cells to get out, like is the lymph node and spleen going to take care of it? But central is the more important one because that's where those T and B cells are produced. Just talking about tissue-specific autoimmunity, so you can have type 1 diabetes, which is like an attack on the beta cells of the pancreas, or you could have thyroid disorders. So there's actually hyper and hypothyroidism. So hypothyroidism, you're producing an immune defense against your thyroid, whereas hyperthyroidism, you're actually producing some sort of antibody that stimulates even further thyroid hormone production. So it's really interesting that the thyroid, you can have like a bad thing with too much or too little. And then if it's a systemic autoimmunity, like systemic lupus erythematosus, you can have many antigens, like just attacking everything, whichever way. All right, so in terms of genetics and environment, the big takeaway from here is going to be the bolded and underlined terms here. So you can have something called molecular or antigen mimicry. So the biggest example of this is that if you get, I want to say it's like strep throat. So you have strep pneumo and you have like some sort of pharyngitis. If you don't treat that within like, I want to say 9 to 10 days, you can actually develop something called rheumatic fever, where your body kind of sees strep pneumo, and strep pneumo kind of looks similar to some heart cells. So your body's going to start attacking the heart cells along with the infection. So it can be really bad, especially for children. Let's see. Yeah, so it's not going to be rheumatoid arthritis. This is rheumatic fever. It's something entirely different. This has to deal with like having a bacteria that looks similar to cells and causes a fever kind of situation. Rheumatoid arthritis is a different ballpark altogether of inflammation. All right, so mechanisms of autoimmunity. So you're going to want to know, like if I say type 2, you'll be able to say that hemolytic anemia fits into there, that myasthenia gravis fits in there, Graves' disease. Whereas type 3 is going to be systemic lupus erythematosus. Sometimes rheumatoid arthritis fits in there, but sometimes it doesn't. And then type 4, there's a couple of them, so that's why I left this blank. Or rather, the fact that rheumatoid arthritis can be both of them. That's why I kept it down there. So this goes back to that whole like hypersensitivity thing. Well, it'll look familiar to it. So type 2 is still dealing with the cell surface. Type 3, you have complexes that form. And then type 4 is still T cell mediated. And then I have like little ways to remember it, like systemic lupus erythematosus, SLE is 3 letters, therefore it's a type 3 autoimmunity. And then I don't have like really cute things to remember type 2, but we'll go through them a little bit. Or maybe we won't. Okay, so let me just talk about them real quick. So hemolytic anemia, this is where you have basically an immune response against your blood cells. So think of like anemia, you remember from renal, like you have iron deficiency anemia, or like any sort of anemia means like probably a low blood cell count. So this is where you have antibodies that are going and attaching to RBCs, and they're being tagged for destruction. Myasthenia gravis, this is where you have like acetylcholine receptors that are blocked and you get weak muscles because of that, so it's kind of like paralysis in a way. And then Graves' disease is that hyperthyroidism, where you actually have an antibody that's binding to the thyroid receptor, and instead of blocking activity, it actually stimulates it. So now you have too much hormone or thyroid hormone on your body, and you're kind of like me. You're bouncing off the walls. You're like your metabolism's great. Like you're just like really overworked. Too much ATP in that body. So yeah. So the big takeaway from systemic lupus erythematosus is that butterfly face rash. That's a dead giveaway that it's SLE. And there are some like other ways to tell. And just in general, SLE is a little more systemic. So you're going to have like complexes or like T-cell mediated, no, it is complexes that are formed all around the body rather than just being localized to like the joints in rheumatoid arthritis. All right, so here are other ways at looking at type 4 mechanisms if we want to look at disease state specific. So I talked about type 1 diabetes. You basically have like immune cells attacking your beta pancreatic cells. And so now you don't produce insulin anymore and you can get like really terrible like glucose control. Multiple sclerosis, this is actually where your somehow your T cells get antigens from your brain, from like myelin sheaths, and they decide that this is foreign. We talked about earlier sanctuary sites, so typically you're not supposed to have an immune cell in the brain, but these T cells will see it as foreign, and they'll go up and try to traverse the blood-brain barrier. They're going to take cytokines and also other sorts of inflammatory mediators, open up those tight junctions, and all of a sudden you have T and B cells in your brain attacking those myelin sheaths on the neuron. So now you can get like multiple sclerosis, and so that's what MS is. And then rheumatoid arthritis is basically you have like your T helper cells and your cytotoxic T cells are like destroying bone and joints, so you get like intense inflammation, especially around like little joint areas like the knuckles. Rheumatic factor, this one's a very important slide. It can come up like once or twice during your exam, but it's basically an IgM antibody that reacts with your IgG antibodies. And this is something that can be found in rheumatoid arthritis, but it's not diagnostic, meaning that if you have rheumatic factor, that doesn't automatically mean you're going to get rheumatoid arthritis. And vice versa, some people who have rheumatoid arthritis don't actually have rheumatic factor. So if somebody is suspected of having rheumatoid arthritis, rheumatic factor is not going to be diagnostic. You want to do further tests or other like cytotoxic assays to figure out if they have it. And that's just a picture of like it attacking like your heart, basically. So autoimmune diseases, so like basically the moral of the story for treating autoimmune diseases is you want to stop your immune system from attacking your body. So you're going to use immunosuppressants, you're going to try to reduce inflammation, and you can use replacement therapy. So for instance, with type 1 diabetes, you don't produce insulin anymore, so you give them exogenous insulin. All right, so I think we're already halfway through. I'm getting through this really quick. Cytokines and biologic modifiers. So this one is just all about the different forms of like specialized medicine that we can use to treat either autoimmune diseases or like other kind of like conditions. So a biologic response modifier will basically alter the function of cells. It's very specialized to where you can like change the function of a helper cell. You can maybe block cytokine production. It's very interesting. The benefits of a biologic is that it's more specific with fewer side effects. So immunosuppressants, as great as they are at suppressing your immune system, they're very non-specific. So you can get a lot of adverse effects. And especially when you think of like steroids, you can get like hyperglycemia, you can get all sorts of bad things that you don't want. You can have, what was it called? Cushing's syndrome or Cushing's disease, where basically now your like endocrine system is really altered to where it's not functioning properly anymore. So some possible functions of these biologics are you can either stimulate or dampen the immune system depending on what the condition is. Is it like poor immune system? Is it an overactive immune system? And then you can deplete different cell populations. So if it's B cells, you can reduce B cells. If it's T cells, reduce T cells. And another benefit that I wanted to point out was that biologics can be used a little more long-term, whereas immunosuppressive agents cannot due to those adverse effects. So I've tried to summarize the different cytokines, what actions they have, and the dose and or treatment. So I tried to bold and underline the important things I wanted you to remember. So for instance, we've got IFN alpha and beta. So these are antivirals, and they're also like considered type 1. interferons, whereas IF and gamma is a type 2 interferon that does like something separate from alpha and beta. So IFN alpha is going to treat hepatitis C. IFN beta is going to treat multiple sclerosis. It actually like is anti-inflammatory, so it can actually like stop T and B cells from getting into the brain, because we talked about multiple sclerosis is an inflammatory response against myelin sheath. So IFN beta will try to like suppress immune response along with like trying to restore tight junctions in the brain. IFN gamma, this one is actually more inflammatory, and it actually will activate macrophages and Th1 responses, and so we're just basically going to use this to treat chronic granulomatous disease. IL-2, as you might recall, actually helps to proliferate T cells. So this one, I want you to take away that we have two different types of mechanisms of using IL-2. We can either bind to the CD25, I want to say it's the alpha chain, to inhibit IL-2 from being produced, and so you can have daclizumab or basiliximab. These ones are the inhibitors. Or you can actually do the opposite, and you can stimulate T cell proliferation if you're trying to treat a renal cell carcinoma, and that's where this aldesleukin comes into play. I want to say that like basiliximab and daclizumab are the more important ones to remember from IL-2 though. And then just for completion, CTLA-4, it binds with B7 with higher affinity than CD28 to C cells. Therefore, it's going to dampen T cell activation. So if you want to dampen T cell response further, you just create like a CTLA bound to like an antibody, and then now you can like dampen the response even more. All right, so TNF-alpha is a cytokine that's kind of implicated in inflammation, recruitment of other inflammatory mediators and cells. And so we want to kind of block this because this is kind of a cytokine that is implicated in rheumatoid arthritis, along with like bowel diseases like Crohn's disease or ulcerative colitis. And infliximab is the biggest one that you want to remember, not only because it's like chimeric, but it's like one of the ones that we do use for rheumatoid arthritis. And then I'm trying to remember, I don't think sertolizumab was tested too much on the exam. I just recall that you're going to learn about it in GI when you're talking about ulcerative colitis and Crohn's disease again. So let me see. And just recall that if it's a chimeric monoclonal antibody, you can have like an immune response built up against that monoclonal antibody because it seems foreign. It's got mouse particles, and that's not human. But yeah, so remember infliximab, and then maybe Intercept would be a good one to remember as well. So this one is more of like, it's a fusion, so it's not like a monoclonal antibody, it's more of like a fusion of like a antibody plus TNF-alpha. All right, so colony stimulating factors, these guys are basically used to produce like neutrophils or other immune cells that have been depleted. The biggest takeaway is that GCSF helps to treat neutropenia and non-myeloid malignancies, whereas GM-CSF treats acute myeloid leukemia. So this will just be something to remember, like which one or which diseases does G treat, which ones do GM treat. So in terms of B cells, these are also implicated in rheumatoid arthritis because they'll produce IgM antibodies that will bind to IgGs and try to deplete them. Systemic lupus erythematosus creates immune complexes with different antigens. So you have an antibody binding to an antigen, and now you have these like particles that are like depositing all over your body, causing all sorts of issues. And so in order to stop this from happening, we can get a monoclonal antibody that stops B cells from producing like so many antibodies against the body. So rituximab, this one's a big one. So you're going to use rituximab to bind to B cell surfaces to stop them from circulating in the body. So now the B cells are depleted, they can't produce antibodies that attack the body. It's specific to CD20, so I want you to remember like CD20, and then earlier we had, I want to say CD25 for IL-2. So don't let those get confused. Like keep them together. Like CD25 refers to IL-2, whereas CD20 refers to like B cells. All right, so vaccines in theory and practice. You've gone over types of immunity quite a couple of times, either in undergrad or in school, so I just tried to put in additional pictures that you can look at the PowerPoint at home to kind of organize them. And then I also did my own little summary of what they are. So if it's natural, it's either you fighting an infection and creating immunity, or it is like your mother giving you antibodies, and that would be passive. Artificial is either you have vaccinations or you are injected with antibodies, like for hepatitis B, where you have antibodies that like will bind and prevent you from getting the disease. And then with artificial, you can also have antitoxins that counts as passive artificial acquired immunity. All right, so these are just features of vaccines. We want them to be safe, protective. We don't want them to have or cause illness or death. We do want them to have more T-cell responses because that's where we form memory. So even though we have polysaccharide vaccines, we kind of prefer to get more on the cell side. And then we want them to be practical, easy to administer. So even though there are vaccines out there that, like, for instance, like cholera or like, I want to say yellow fever, they're not practical to use in the U.S. because we don't get them as much. Versus if you're going to be traveling, that's when you would be indicated to get those vaccines. Versus like everybody should get their DTaP, everybody should get MMR in the United States, etc. All right, so special populations. Biggest takeaway: pregnant and immunocompromised, these guys, you want to be careful about what vaccines you give to them. With pregnant women, rubella from the vaccine can still cross the placenta, so don't give them the MMR. Try to make sure they had it either before or give it to them after they've given birth. And then immunocompromised, their immune system's not working properly, so that virus or bacteria that you inject into them, if it's live attenuated, it could mutate back into a viral form, so that's why we don't give it to them. Here are the types of vaccines. I organized it by live attenuated versus non-viable. And then once again, please don't give live attenuated to pregnant or immunocompromised patients. Non-viable, these mean it's either like part of a microbe or it's a microbe that's been like inactivated with formalin, so that it's not going to cause disease at all. If anything, it's just laying there for your body to pick up and develop an immune system against. So there are usually a lot of non-viable vaccines, but there's only like a couple really of live attenuated. So if you can remember the live ones, you'll remember that everything else is like inactivated, whether it's a toxoid, polysaccharide, subunit, etc. So the ones that are live that you want to remember are MMR, varicella, and then like there are influenza. There's both inactivated actually and activated forms, but I put it in there for completion's sake. And usually, like, I remember that MMR and varicella are subcutaneous, whereas the other ones are intramuscular, so that's how I remember these ones are live. Look over this to kind of like summarize in your mind the different types of vaccines this way. Going specifically into toxoid and polysaccharide and all those different types of inactivated vaccines, toxoids are basically toxins that are taken out from bacteria, and then they're purified and then inactivated, so they can't like cause like an issue in your body. They're just there for your body to identify. So examples would be like diphtheria and tetanus. Those are like toxins. And then DTaP would be an example of a vaccine that has toxoids in it, and they're bound to acellular pertussis. Polysaccharides, you can divide these into either purely polysaccharide or conjugate polysaccharide vaccines. So these are antibodies that are against bacterial capsules. So strep pneumo is going to have a polysaccharide capsule, Neisseria meningitis, and then like Haemophilus influenzae, they all have capsules that we can develop vaccines to target and pretend to be these bacteria. So for a capsular polysaccharide, it's going to be T-independent responses because we don't have like a protein for a T cell to recognize. So now we're relying on other parts of our immune system to recognize this vaccine as foreign and to build an immune system. So they're not really good in infants because infants don't have an immune system that is mature enough to develop a defense against the bug. And then elderly, they might just have like a poor immune response to it. Conjugate, however, this is where you actually take the polysaccharide and you add a toxoid protein to it. So that protein will be recognized by a T cell and now you do develop an immune system and memory against that polysaccharide. So this will be like your, I want to say Prevnar, some meningitis vaccines that we'll go over. And just like a key point to remember is that a conjugate vaccine, it's not the same as adjuvant. So if it's like a polysaccharide plus a toxoid, that's considered like a conjugated vaccine. Adjuvants are more like they help to increase an immune response if you're not going to develop it as easily by itself. But as you can see, like capsular polysaccharide, I didn't talk anything about like adjuvants in there. So yeah. Otherwise, like with conjugates, they help you to create the memory. Otherwise, they're not going to form it. Subunit vaccines, this is where you take like either serotypes or different portions of different strains of vaccines and put them together. So these are portions of a pathogen. So examples would be like either the hepatitis B vaccine or human papillomavirus. You take subunits like strains like 16 and 18 so that your body can try to build a defense against those so you don't actually build an infection later on in life. Reassortment, this is where you take like a bunch of different viruses and generate a new virus that doesn't replicate. In other words, it can't cause any sort of immunogenicity, can't cause any infection. And rotavirus for diarrhea, this is an example. So children will ubiquitously be susceptible to rotavirus. So this vaccine right here will help them to like not get that, because diarrhea can be bad for a baby. They can get dehydrated and it can be really fatal if you don't treat it properly. And then this is kind of like intuitive, but there are so many ways to make different vaccines. So like if you see a question on the exam that's like, which one of these is a way to make a vaccine, it's probably going to be like an all of the above thing. So you can recombine them, you can put them in yeast and clone them, you can add aluminum to make them stronger or like elicit a stronger response. You can take a live vaccine and cold adapt it. You can take an you can make an inactivated version for patients who can't take live vaccines. There's many different ways to make a vaccine. In terms of formulations and routes of administration, we'll start with formulation first. Aluminum is considered an adjuvant. This you add to a vaccine to make sure that your body properly responds to it and develops an immune response. It is a way to make sure that that pathogen gets recognized and you build a proper immune system. Whereas an additive, this is more of like a byproduct that was left over during the manufacturing. So for instance, if we make like a vaccine in like egg, you might get a little bit of egg protein left over, like with the influenza vaccine. So that's why maybe you want to be concerned about that when administering to patients with egg allergies. Antibiotics like penicillin might accidentally get mixed in, so this can cause contact dermatitis. MSG, I like to think of like Chinese restaurants as being the places with MSG, but sometimes they can be additives as well. And these, if they get into your body, can cause like nausea, like headaches, just like generalized GI pain. Gelatin can be used to help protect live vaccines. So you might want to be careful with gelatin with, like, for instance, I want to say Jewish patients, because gelatin is made of like pig cartilage and stuff. So it might be against their beliefs to use something with that kind of product in there. And then latex, of course, you want to be worried about, like we said earlier, reactions to latex. So for routes of administration here, the biggest takeaway is that oral and nasal are going to produce both IgG and IgA responses. So the IgA comes from the mucosal areas, so your mouth and then your nose. So these ones prime the immune cells at that site. So if you get like a pathogen that usually is inhaled, now your body or your nose is going to have a defense mechanism against that pathogen. Oral, same thing. Like if it comes through like a fecal oral route or like it's something that's ingested, you can build an immune system that is not only like now you have memory in your body, but specifically in those areas where the bacteria or virus would penetrate. And then subcutaneous vaccines include like MMR and varicella, like I was saying earlier. And all of these will, like, all vaccines will produce IgG responses. Save for like some of the polysaccharide capsules or vaccines will only cause like IgM, low memory responses. But for the most part, remember, mucosal means IgA. Everything else is IgG. All right, so we're almost through with this, vaccine preventable diseases. We know about herd immunity, but basically In order for it to be effective, we need almost everybody to be vaccinated. It's a way to make sure that people who are vulnerable don't get illnesses that they don't need because it's preventable, but sometimes they can't get the vaccine, so we're going to protect them on their behalf. So the less people that are vaccinated, the less effective it is. All right, so I kind of went through the slides of all the vaccines and tried to summarize the types. I don't recall too much being tested on like what the bacteria or virus caused. Maybe like the rotavirus causes diarrhea, that would be one to remember. But the other ones, they were kind of just more geared towards what kind of vaccine it was. Is it conjugated? What kind of response does it do? And just being able to identify the like name to the type of vaccine. Just in a little bit, I think Gardasil and Cervarix was another one where you wanted to remember that it treats HPV, but we'll get to that. So for starting at the top, we've got DTaP. So this is, like we said earlier, toxoid, because we've got the diphtheria and the tetanus toxoids. We've got pertussis in there as well, but it doesn't have an endotoxin. It's just acellular so that your body can detect it and build an immune system against it. And then we do use aluminum for these and combine them with pertussis, because we want to develop like a stronger immune response and be able to like actually identify it in the body. This is true for a lot of like inactivated vaccines versus live attenuated. Live attenuated are more potent and will produce memory. The inactivated ones, sometimes we have to give a little bit of help for our body to recognize it. Otherwise, it just sees something like floating and it's like, well, this isn't doing any harm. I don't need to treat it. But the aluminum will make them go like, oh, yeah, no, that's bad. We need to take care of that. So HIB is the Haemophilus influenza B vaccine. This one is conjugated. I think you'll definitely want to remember that Hib is a conjugated one. You want to remember all the ones that are conjugated versus which ones are just polysaccharides. But this one, it is conjugated to a toxoid so that that polysaccharide can be recognized by the body to elicit like a T-dependent response. This isn't the same as like the influenza virus, so this is a bacteria that we want to make sure that, because like you won't see this a lot unless you have like a patient who's 2 years or younger. If you're above 2 years old, you're probably not going to see a patient with Haemophilus influenza. You're going to see them with the influenza virus. So PPSV23 is a polysaccharide vaccine against Streptococcus pneumoniae, so it prevents like pneumonia. And this one is T independent, so some children might not respond well to it. So this is the one that you kind of like give as like a booster to elderly patients after they turn 65, for instance. Whereas PCV13 or Prevnar, that one is also against strep pneumo, but it's a conjugated polysaccharide. So this one actually has diphtheria attached to it to produce like a memory response. Menomune and Menactra and Menveo, they all treat meningitis. However, Menomune is the capsular like polysaccharide only, whereas Menactra and Menveo, they are conjugated to diphtheria again. So yeah, if you're conjugated, you're going to develop a T-dependent response versus capsular is T-independent. All right, let's see. Yeah, so this is the other slide. I was able to get this all down in 3 slides. I was really proud of myself. But the Sabin vaccine is for polio. And this one is live attenuated. We don't really have this anymore due to the fact that we are worried about like immunocompromised patients. If they take this vaccine, like we were saying earlier, a live one could revert back to viral. And plus, like we've pretty much eradicated polio, so we're not going to see this in the United States a whole lot. Whereas Salk is also polio, but it's a killed virus. So you take 3 strains of polio, you inactivate them, and then you use this as a vaccine. So I think Dr. Hodge already talked about like how she remembers it, but you can't sulk with Salk, so that's why you use Salk if you are going to use a polio vaccine. So yeah, that's a way to remember it. The MMR vaccine is also live attenuated, and once again, 3rd time in a row, don't give them to pregnant or immunocompromised patients because their rubella can traverse the placenta, and then live vaccines could be detrimental to immunocompromised patients. Zostavax and Varivax, they're used for chickenpox. Key takeaway points, you don't use these interchangeably, so you can't use one for the other. You do like Varivax for the chickenpox, and then you use like Zostavax, or I think like Shingrix for shingles. Havrix and Vacta, these are for hepatitis A, so I think of like hepatitis A virus. And then the other, I don't have a mnemonic for this one, but they're all inactivated for hepatitis A. Recombivax, they both have like B's in their name. That's how I remember that. Maybe that's how you can remember it. This one has A's in it. This one has B and B in there. So these two will treat hepatitis B. We've got your flu vaccine, which could either be live attenuated or it can be inactivated and recombinant. Rotarix, Rototec, it's the Rota virus, so they're going to help treat the rotavirus, which causes diarrhea in children who are 5 years or younger, usually. And then Gardasil and Cervarix are for human papillomavirus. Dr. Hodge hasn't really, well, I don't know if she updated her slides. I need to check back again, but Gardasil now has like 9 types, so it's nonavalent. And then Cervarix also has like 2 serotypes, so these are used to treat or to prevent HPV. All right, so here's another way to organize the vaccines based off of like live attenuated versus inactivated. So if you learn better by charts, this might be good for you. So I put it by like subcutaneous. Actually, I'm sorry, I think that needs to be intramuscular. So this is like injectables rather. This one's like oral mucosal, polysaccharides, subunits, toxoids, and viruses. All right, so I've got questions. I'm going to do this the same exact way I did last time, where I'm just going to pause my own voice for 5 seconds, and then you can like pause it in real time, and then I'll go over the answers. All right. All right, so this one is just a kind of like a recall matching question. So I've got all those there. Latex is actually going to be Hevine. Dust mites are going to be Derp. Cockroaches, that's right, Blag. All right, so this one's going to be IL-4. This one's indicated in A to P. You're going to have high serum concentrations of it. And then I've got just examples of what the other interleukins do. This one is GCSF, so this one treats neutropenia as well as non-myeloid. And then all the others there, alpha and beta, they treat antivirals, or they're antiviral rather, and they also can be used for hep C, multiple sclerosis. And then GM is used for acute myelogenous leukemia. So this one's going to be DTaP. DTaP is going to produce IgG. The other ones, this is kind of like a kind of connect the dots question where secretory IgA is going to be produced because of like mucosal passages. So the nose and then the mouth. So live is going to go through your nasal route. Sabin and Rototec you're going to take orally. All right, so Prevnar is going to be the conjugate in this case. The other ones are either polysaccharide or Cervarix is a subunit. The other conjugates were like HIB, and then I'm going to say Menactra and Menvio are the conjugate meningitis vaccines. So know the difference between polysaccharide and conjugate. So this one's a type 4, so looking at the tuberculin test, this is delayed because if you recall, when you get that PPD test, you have to come back in 48 to 72 hours later, so it's not immediate. And then I've matched the others appropriately. All right, so this one is that multi-level one where you have to figure out, first of all, what kind of reaction is it? Is it graft versus host, or is it just a transplant rejection? And then you match up the HLA types. So in this case, bone marrow, that means that it's going to be graft versus host. So we care about what the graft has, and then the host has to match up with the graft. In this case, we have HLA 1 and 2. So typically if it's heterogeneous like that, if it's 1 and 2, it's going to mean that it's going to be accepted or it's not going to attack the body. So down here we see that our graft has A1A2. We have like a homogeneous HLA with the recipient. It's A1A1. So this one has an A1, so it sees these as it like, similar, so it's not going to attack. So this one is going to be Graves' disease is type 2. The other one, systemic lupus erythematosus, would be type 3, that SLE, 3 letters. Myasthenia gravis and hemolytic anemia are both type 2. All right, this one's just celiac disease. Just remember gliadin is corresponded to celiac. So this one, actually none of the above are correct. So remember, rheumatic factor is not diagnostic. If you have rheumatic factor, that doesn't mean you're going to get rheumatoid arthritis, and vice versa. If you have rheumatoid arthritis, you don't necessarily have rheumatic factor. The other thing to remember is that rheumatic factor is an IgM antibody that has affinity for IgG. This one's going to be aluminum. It's an adjuvant. It helps to increase the immune response. The other ones are just manufacturing products that were left over. So this one is least likely to cause immunogenicity. That would be autograft. Think about it. Like, you've got skin cells or whatever from yourself and you're transplanting it elsewhere. It's yourself. Your body's going to recognize it as you. Whereas xenograft is different species. That would be the most immunogenic. So autograft is going to be least, followed by like an identical twin, followed by allograft, followed by xenograft. This one's going to be acute is corresponded to days to months. Hyperacute would be minutes to hours. Chronic would be like a year or more after, where you have those like blood vessel thickening reactions happen. Hyperacute, like you instantly reject it. Acute, you might be able to use immunosuppressives in time to stop your body from rejecting the transplant. This one's going to be natural passive, so this is where your breast milk can like secrete IgA, so it's passive and it's natural. And then here are the others, like natural active would be like your body's fighting an infection. Artificial active would be vaccines. Artificial passive, antitoxins, immunoglobulins. All right, so this one, basiliximab, is going to bind to the CD25 chain of IL-2 and block proliferation. The other ones there, I have all the examples. Oh, I didn't say it during the PowerPoint, but the way I remember Anakinra, I think of like Anakin, you were the chosen one, so it's like IL-1. So the other ones you just have to create your own little mnemonics for, but I thought that was kind of cute of me. All right. So this one is all of the above. I know Dr. Fix doesn't like using cimetidine, and I personally wouldn't use it either because it has a lot of like CYP interactions. However, all these are viable options to treat poison ivy, and all the mechanisms are listed here for you. So this one is true. So this is where I was talking about how you take the recipient serum, you take the donor lymphocytes, you put them together. If there's a reaction, then they're incompatible. If there's no reaction, no response, then you can actually use it and it's probably not going to reject the transplant. All right, so that's all I have for you guys. I hope that the practice problems help a lot. Look over those flipped classroom questions, and they're not always, as you can tell, they're not going to be word for word on the exam, but sometimes they're going to be similar. So the way I would look at it is look at those questions and figure out how to make the wrong answer choices correct, like what would make them reasonable answers. Also, I would Google charts and stuff. That's what you saw all throughout the lecture here. If you're having a hard time visualizing it, I know the Immunology textbook isn't that great. At least it wasn't for me. So you can look up other graphs to help you out. And please get a good night's sleep. Don't get like too stressed about it. Don't try to stay up overnight. And there's my little hedgehog, Peter Parker. He was sleeping in my shoe there. But yeah, good luck everybody, and I hope you have a wonderful, I guess, like weekend studying.